In the interest of time, we'll start now. Good afternoon yet again to those that have been here before and those that have just joined on, you're welcome. My name is Dr. Alupo Patricia. I'm a physician and research fellow at the Makerere University Lung Institute, and I'll be your moderator for today. And we have a very exciting and interesting dual session ahead. Particularly because we are tackling a very unique aspect of COPD, which for long we haven't paid attention to. And this is in commemoration of the International COPD theme, which is aimed at looking at the earlier actions that we take towards prevention and management of COPD. Breathing is life, and we need to act earlier. And so from time immemorial, we have known COPD to be an adult disease, especially older adults. But progressively, we are understanding that it's not only about for the adults, but even the children and their early life determinants and risk factors to COPD. So today we have very interesting and seasoned speakers. The first is Dr. Rebecca Nantanda, who is a pediatrician and senior research scientist at the Makerere University Lung Institute, who has done extensive research in pediatric airway disease. And she'll be our first speaker taking us through this. And then she'll be followed by Dr. Ahmed Ddungu, who is a physician and research fellow at the Makerere University Lung Institute, to help us understand and appreciate the need to act earlier when it comes to COPD prevention and management beyond just adulthood, but also in the pediatric and in utero period. Dr. Nantanda, you're welcome. The floor is yours.
Thank you, Dr. Alupo. I hope you can hear me. Can somebody confirm that you can hear me?
Yes, we can hear you.
Yeah, thank you, Dr. Alupo, and it's exciting to be part of this presentation today. I just decided to show my face a little bit for those who may not know me, but I'm just going to switch off my video in the interest of having enough bandwidth. So I'll share my slides and start the presentation. So we are talking about the early life origins of chronic obstructive pulmonary disease. It's kind of eyebrow raising when a pediatrician is talking about COPD, which is a diagnosis made by colleagues, the physicians. But we want to understand how people end up with signs and symptoms of COPD and what we must do differently if we are to prevent this debilitating disease. So the theme for this year's World COPD Day was breathing is life and act earlier. And so we are going to discuss what do we need to do early in life so that we are able to prevent COPD and therefore be able to breathe properly without any problems. And so for this presentation, I'm going to focus on two things: why we need to act earlier and give some direction on how we can act. And in that respect, I'll be looking at the normal lung growth and development, discuss the early life factors for lung development and how they influence the risk of COPD, and then make some suggestions about prevention. And this is specifically going to focus on primary prevention of COPD. But first, we need to understand COPD. And so it's a heterogeneous disease. Usually when something is heterogeneous, it means the presentation is in many ways. The risk factors are also heterogeneous, but also the pathophysiological mechanisms may be heterogeneous, making it a complex disease. So COPD is a heterogeneous lung condition. It's characterized by chronic respiratory symptoms, usually cough, sputum, and difficulty in breathing. So it's a chronic disease. And there are exacerbations from time to time. And all these issues are due to abnormalities of the airways. And so you're looking at the entire structure of the lungs from the bronchi, the bronchioles, as well as the alveoli. So it's a disease that is going to in fact affect the entire lung. And it causes persistent and often progressive airway obstruction. So there is no reversal, there is just really deterioration until you pass on. So such a disease, I think the best option for us is to find a way how we can prevent it in the first place. What is the burden of COPD? It's the third leading cause of death globally. It causes about 3 million deaths annually. Unfortunately, like many conditions, 90% of these days occur in low and middle income countries, Uganda inclusive. And if you look at the morbidity, around 390, almost 392 million people suffer from COPD. Again, the greatest burden of 80.5% are people living within low and middle income countries. The prevalence is slightly higher in men. If you look at the global prevalence, 15.7, and for women, it's a little less. But if you look at the statistics that is specifically for sub-Saharan Africa and maybe Uganda, you'll find that women are probably more affected, and there are different factors which my colleague will discuss later on when he's talking specifically about COPD. And looking at this debilitating disease in the sense of in the Ugandan context, when people have COPD, usually we need to use spirometry to make a diagnosis. And in our health facilities, whether private or public, the study that was done about 4 years ago indicated that only 24.4% of our facilities actually have a spirometer. And we are not even certain whether it's used constantly all the time when it's required. And then the cost of medicines for COPD is also unaffordable for most of our people. You would need an average of 3.3 days wages to treat COPD compared to other LMICs like Nepal and Peru, where it's about 0.47 days wages. So it's both a big problem by the number of people it affects, but also in terms of really caring for those people who are affected, it's a challenge within Uganda. And therefore, primary prevention may remain the mainstay for us to deal with this big problem. So what is it about the early life that really makes somebody susceptible to COPD? It's about the first 1,000 days of life. And this is the period from conception to up to 24 months, the postnatal period. And just like any other NCDs, COPD, its origin can be tracked in these first 1,000 days. And therefore, whatever prevention mechanism we may be thinking about should be largely focusing on this period. This period has been termed as a window of susceptibility. And this is because most of the structure and function abnormalities occur around this time. And there is rapid development of tissues and organs. But if there is any insult to any organ, including the lungs, it actually leads to permanent remodeling. And this is how people later on in life manifest with COPD symptoms. Just a brief about what happens in utero. I'm going to focus on the in utero period because I think that's where we can start from, since we have antenatal care going on and a number of people actually attend antenatal care in our facilities. So if you look at lung development from 0 up to 36 weeks, there are different stages. I'm not going to go through all of them, but just to mention that there is the embryonic stage where we have the bronchi developing, then later the bronchioles, then eventually we have the alveoli. So it's a process that is systematic, goes from one stage to the other. But what I want to mention that if there is any insult at any of those stages of fetal lung growth and development, then by the time the baby is born, their lung function is suboptimal. And there is a lot of evidence that has shown us that if somebody is born with suboptimal lung function, they have a high risk of developing chronic lung diseases later in life, including COPD. So the insults need to be prevented at this critical stage of lung growth and development. So this is just a figure that shows what is happening during the intrauterine period. So here we have the placenta side, and so we have the mother being exposed to different toxins that I'll explain later, and these find their way into the bloodstream. So first, they affect the placenta. We know that the placenta is the one which basically feeds the baby. So if there is anything that is going to impact on the health of the placenta, it will certainly affect how much the baby feeds. But on top of that, if anything is coming through the bloodstream from the mother's end and crosses placenta, it will find its way into the blood and through the cord of the baby, and therefore will eventually affect the organ growth and development in the babies. So the issues that I'm going to describe, the risk factors, we should always have this in mind, that it starts with the mother being exposed and the placenta being affected, but also the toxins crossing from the mother's end to the baby's end of the placenta and through the cord, and eventually through the rest of the system of the baby. So if things go right in the diagram that I described above, this is what happens to the lung function. So we have somebody born here, and if you follow the green curve, this is what most people would follow. So you have lung growth and development or lung function indices improving, and they peak around 20 to 22 years of life. And then you will naturally have lung function decline. This is a normal process. But for people who start off, who have been affected during the prenatal period, they may show that their lung growth may be okay, but then they have a very accelerated decline in their lung function. I think this may be very few, but what we know that for most people, once they are affected during the prenatal period, by the time they are born, their lung function is actually lower than the normal, the average, and they will follow that particular line, or what we call the trajectory. So they will never achieve maximum lung function. And because of exposures they may go through in the extrauterine period, some of them may actually have a very fast lung function decline. So the message is, if you start off poorly, probably there are very few people who will have the catch up to the normal, but majority of the people will follow this same lung function trajectory, and therefore they're at risk of developing lung health problems or lung disease earlier on in life, because they never in the first place achieved what was supposed to be the maximum or the optimal lung function. I'm just going to demonstrate this when I look back a little more into the prenatal period. Again, this is at the time of birth. So if things happen normally during the prenatal period, that child or that person will have a normal lung growth and lung function. And then it will peak, like I mentioned, at around 22 to 25 years. And then they will have the normal decline like anybody else. And so if they are to develop any lung symptoms, if they are to really extrapolate this curve further, probably it will be in their next life at all, if at all. But if they have any prenatal exposures, and some of them I'm going to highlight them, even during the in utero period, by the time they are born, their lung function is not optimal. And like I mentioned earlier, so their lung health trajectory is going to be suboptimal throughout their life. And then the decline will also take place, because it must take place. But as they grow into adulthood, then they will manifest the symptoms, because they started off poorly and they followed the same trajectory, and then they show the symptoms. So these are the people, because of what happened during the prenatal period, will actually develop chronic lung diseases, including COPD, and manifest with the signs and symptoms of COPD. So the importance of avoiding this track is extremely important, as we shall see later. So what are these things that may affect lung growth and development in utero? So we have environmental exposures, and nutrition hasn't been mentioned a lot in most of the literature, but there is really emerging evidence that nutrition, both during the prenatal and childhood period, is extremely important for lung development. And if it's not optimal, children will end up with suboptimal lung function and therefore a high risk of COPD. Exposure to air pollutants, and these may include biomass smoke, especially from cooking, but also traffic-related air pollution, either for the but also for the child. Tobacco smoke has been extensively studied, and that's why during the obstetric history, we actually ask about tobacco smoke. But these are also important exposure, both in utero and childhood. There is a lot of evidence now that if a child has recurrent lower respiratory infections, it affects their lung function, putting them at risk of chronic lung diseases like COPD later on in life. There is genetic influence. There's some research that shows that this influences the lung function trajectories and therefore can influence the risk of COPD. And then issues around obstetrics. If a child has intrauterine growth restriction, if they are born prematurely, or if they are born with low birth weight, they have usually suboptimal lung function because of those factors that lead to preterm birth or low birth weight, and eventually end up with high risk of having COPD. So what I'm trying to say that for as long as you have suboptimal lung function in early life or in childhood, this will be associated with increased risk of asthma and COPD, and therefore we must focus on these risk factors to try and prevent COPD later on in life. I'm just going to share some evidence from Africa. So this is the study that is done by the Lung Institute. It's a birth cohort study. We call it the Impala birth cohort, done in Chamliwa in rural Uganda. And I'm just going to share the preliminary results from this study to really show the impact of maternal diet on the lung function of the children. So in this cohort, we enrolled 564 pregnant women, and we are able to have valid lung function tests in 402 infants. We did tidal volumes, we did mean tidal inspiratory flow and mean tidal expiratory flow and other indices of lung function in this age group. So we did this lung functioning between the age of 6 weeks up to 1 year in these children. So we tried to find out how is the diet of these mothers. And the key issues that are important in terms of lung function is the fact that when you look at those foods that are rich in vitamins and minerals, which are important in lung function growth and development during the in utero period, there is a very low consumption of these, from 6.6 up to 41%. The same thing when it comes to fats and oils, as well as the animal products. So these products or these foods are really extremely important because they contain those vitamins and minerals that have been found to be very important in lung growth and development during the prenatal period. But when you look at the consumption by this particular group of people in this community, it's on the lower end, and therefore you might predict that the lung function of these babies moving forward may not be optimal, and therefore they're at risk of COPD. So we did try to look at the associations between the mother's diets and the lung function. The table was so big I couldn't put it here, but I just want to mention the overall findings that came through, and I want to mention that these are really preliminary results. We are still analyzing. The important thing is that the findings are really mixed. There are those babies whose mothers consumed certain foods frequently, and they ended up with a higher mean of lung function. And then there are those who we thought, because they consumed certain foods and therefore they would have high mean lung function, but on the other hand, we found that it was the reverse. And we found that there were significant associations between the frequency of consumption of foods and lung function, which are not consistent across all the indices. In other words, it was not possible to pin to particular foods, let me say greens or milk or eggs, that this particular food is associated with good lung function. And what we derive from this is that when we are looking at public health programs, instead of recommending nutrients, we should be looking at a holistic diet for the pregnant mothers, because we know that these foods work in form of synergy to actually improve the health of the mother and therefore the lung function of their babies. The other key finding was the fact that when you look at the diversity of the foods that the pregnant mothers eat, it is different during pregnancy and after birth. They tend to eat very poorly during pregnancy, yet it's a critical period, and then they eat better foods after birth. probably it's from the cultural context that you want to get breast milk. Again, we have to have these messages coming through about the importance of optimal nutrition during pregnancy. And then lastly, that we looked at household food security. It was not, we found out that household food security did not necessarily translate into better diets for the pregnant women. And we wondered, why is it that foods that are secure food-wise, the mothers do not have access to these foods and therefore have good nutrition and therefore lung function of their babies? These issues need to be interrogated further to try and have proper interventions if we are to improve lung function and therefore prevent COPD. The second study is about household air pollution. This is a study that was done in Ghana, and they measured carbon monoxide exposure during pregnancy. And the key findings was that carbon monoxide exposure was associated with reduced time to peak tide X-ray flow, expiratory time. This basically means that there was poor lung function. It was associated with increased respiratory rate as well as increased minute ventilation. So for all the lung function indices, for as long as the mother had high levels of exposure to carbon monoxide, their babies ended up with suboptimal lung function. And therefore, this puts them at high risk of chronic respiratory diseases, including COPD. And then the last study I want to highlight is a study that looked at respiratory tract infections and lung function, again in a birth cohort of about 1,000 something children. This is in the Drakenstein Child Health Study in South Africa. And this is a birth cohort of about 10 years. So what they did, that they measured lung function for the children at 1 year. They had measured their lung function at 6 weeks, and therefore they were able to track at 1 year, 2 years, and so forth. But for this particular study, they looked at lung function at 1 year in 648 children, and they looked within that past 1 year, 150 babies had had episodes of RTIs. And what they found was that having lower respiratory tract infections was independently associated with increased respiratory rate, which is a marker of poor lung function. But very important, if there were repeated episodes of the respiratory tract infections, again, there was increased respiratory rate, decreased tidal volumes in these babies, as well as increase in the lung clearance index. So recurrent RTIs need to be prevented because, again, as this study shows, the risk factor for poor lung function, and this puts these babies at high risk of developing COPD later in life. So I want to summarize prevention. How can we prevent the scenarios that I've described above? Again, focusing on the theme of breathing life is life and acting earlier. And these are the ways I think we can act. We need to ensure that there is adequate maternal nutrition, of course, not forgetting early childhood nutrition, but because I was really focusing on the prenatal period, the importance of mothers feeding with adequate diets, to reduce exposure to air pollutants. And within the Lung Institute, we are doing some studies to really intervene, looking at clean cooking fuels and technologies. So we've had what we call the Midwife Project, where we have the midwives providing classes or sessions on air pollution and its effects during the antenatal clinic. And we have found out that mothers are actually able to get this information and use it in their home by reducing exposure without necessarily putting in a lot of money to do this. And currently, we are going to implement what we call the Clean Air Africa program. Again, this is focusing on educating communities about how to reduce exposure from air pollution associated with cooking. Then we need to avoid exposure to traffic-related air pollution. I usually think of the people at the roadside, they're roasting the plantain, making Rolex and so forth. Again, if this is a pregnant mother, much as they are trying to find a living, they're also exposed to this and their babies at risk of poor lung function at birth. Prevention of respiratory tract infections, vaccination, optimal breastfeeding, complementary feeding, PMTCT, all these interventions that are going to ensure that we don't have children having recurrent RTIs are going to be very important. And lastly, to prevent those conditions like intrauterine growth retardation, premature birth and low birth weight, because such children are prone to suboptimal lung function and therefore the risk of really COPD later in life. So what I'm trying to say is that the business of preventing COPD is everyone's business, as we have seen that the problems actually start early. I want to really end this short discussion here and hand over to my colleague, Dr. Ddungu, who is going to take us into the details of COPD. Thank you, Chair. Over to you.
Thank you, Dr. Rebecca, for this enlightening talk. It has helped us appreciate beyond the importance of appropriate nutrition after delivery, but also prior, during pregnancy, and the fact that it's purely not only after the child has grown that the risk factors now start being prominent for COPD. For those of us that may have questions or comments, we'll take these at the end after the second speaker has spoken. So you can either put them in the chat or at the end of the second talk, just put up your hand and then we'll be able to interact and hear from you concerning any questions, additions, or comments that you may have. At this point, I would like to invite our second speaker, Dr. Ahmed Ddungu, who is a physician and research fellow, to help us see the other aspect of COPD as well and its prevention earlier on, looking at the adult perspective. Dr. Ddungu, you're welcome. The floor is yours.
Thank you very much, Patricia. I'll show my face before starting, just like Rebecca. Good afternoon to everyone, and welcome to our Day of Lung Science. So the focus of my talk today is COPD, and I would like to draw our attention to the non-smoking phenotype, because this is the predominant one, as we'll see from what I'm presenting in our LIC setting, largely because of variable wear levels, a wide availability of other risk factors other than smoking in our setting. So the definition is the same, and this has already been said, so I will not go again to that, but I'll go to the background. An earlier review by Salvi and colleagues showed that up to 40% of COPD was prevalent in non-smokers. And when you came to look at because smoking is widely more associated with men, except in certain countries, COPD has a predilection towards men, especially in the older population. However, in our setting, because of work from even sentinel studies like the fresh air, you would see that we had a large presence of women and an earlier presentation coming in with COPD, and that's largely because of other risk factors in our setting other than smoking. So the Global Burden of Disease study of 2019 showed that contribution of smoking to COPD was about to the daily disability adjusted life years per 100,000 population for smoking was 44.6%. And this effect varied, but also was higher in the high income countries. This means that low income countries have other risk factors that stand out other than smoking as cigarettes. Now, the fact that we know cigarette smoking as the biggest risk factor, this is what tends to trigger diagnosis and even screening, while ignoring the non-smokers who also have a large COPD burden given other risk factors. So these are some of the large studies that have looked at the burden of COPD in non-smokers. And you can see that as low-income countries, we do not have a presence in this data. And therefore, the conclusions may not really relate to the burden that's reflective of our setting. Nevertheless, you can see that when it comes to looking at the prevalence of COPD in never smokers in these high-income countries, you can see that the highest you can see on that table is 12%. But again, when you look among the COPD patients, you look at the burden of non-smokers, you can see that it can go anywhere up to 40% and even 50% in the study from China, which is on the second last line. So what does this tell us? That again, as I had earlier said, that there's a large presence of COPD in the non-smoking population. Now, this map shows the disability adjusted life years COPD DALYs attributable to the different risk factors of COPD, and also does show the prevalence of COPD per region. You can see that the Africa region, the general overall prevalence is about 13.9 or 14% of COPD, while in America it's 13.2, Europe 12.4, Asia 13.5, and Oceania 11.6. Now, despite the fact that the COPD prevalence is nearly the same, when you come down, you can see the different colors reflective of social development index, social demographic index. And you can see that Africa, we are in the lowermost, which is the red one. And when you come to look at the low social demographic index, you can see that we have just a minute. Tobacco smoking, which is purple, contributes 29% in our COPD risk burden, while things like household air pollution contribute 39%. When you look at particulate matter, it is 16%. Occupational exposures are 13%. This is different, for example, in the high SDI countries where you have smoking contributing 74%. So you can see that there is an inverse relationship between the social development demographic index and the contribution of non-smoking risk factors. I hope that's clear. Now, when it comes to what are the other risk factors of COPD other than smoking, when we come to air pollution, it's estimated that in the burden of COPD, 50% of the burden of COPD in low and middle income countries is attributable to air pollution. And in one of the studies in the UK Biobank study, they were able to demonstrate that the risk of COPD increased consistently with the amount of exposure to PM 2.5, PM 10, as well as nitrogen dioxide. Now, biomass fuel is the highest source of indoor air pollution, and you also know very well that this is largely prevalent in our countries as a result of fuels that we use for cooking, both charcoal stoves, wood, and other things like that. What's interesting is 2 hours per day of biomass fuel exposure for 13 years was demonstrated to show a lung decline equivalent to 10 pack years of smoking. Now, this would not surprise you as to why COPD is quite common in our women and coming at a younger age, because the cooking and all expose people to lung function decline much earlier. And you can see that it's almost another form of smoking. There are other silent things that come down due to lack of awareness. For example, burning. Remember when we burn mosquito coils, we burn them when the windows are closed because you want to be as effective as possible. But burning one mosquito coil generates an amount of PM 2.5 that's equivalent to 100 cigarettes. So you can imagine if you do this consistently every night, and sometimes you have a pregnant mother, as Dr. Rebecca has just shown us, then you can only imagine how much exposure comes down to what we are using as that's causing air pollution, but also attributable to lack of education and awareness. Now, for this kind of risk factor, we need, one, to have policy to set targets for air quality. And this comes not only to indoor air pollution, but also outdoor diesel engine guidance on targets of emissions from factories and the like. The other thing is we also have to accept that this is going to be an integrated effort. For example, healthcare providers need to educate, advise on risk factors. The industry needs to help us design cheaper cooking technologies like LPG, and government has to come in and offer incentives and has to demonstrate a political will to curb air pollution. So together we can formulate policy, but in a multidisciplinary approach, because you might find that government is not sometimes aware of how much risk is posed by certain things like, for example, old diesel engines. Then we also have to increase awareness like we're doing right now, but also to go to the grassroots to advise, because LICs need to focus more on preventive strategies. Reason being, we don't have enough money and to afford the diagnostics as well as the care. Then we also have to do research, because you can see that these are individualized risk factors which are unique to our poor setting, and may not, the treatment strategies available may not necessarily speak to the type of disease that is prevalent in our settings. So the other risks are things like asthma, and it's been shown that the risk of COPD is increased by 12 times in adults who have asthma. For anyone who has lived with asthma from childhood, by the time you reach adulthood, your risk of COPD is increased by at least 12 times. Now, the data shows that this risk is high, asthma and COPD risk is highest in high-income countries. But many of us on this call know that the studies which have screened for asthma, including the asthma survey in Uganda here, have shown that we have a high burden of, I think, anywhere up to around 22% in some settings of asthma, even in rural settings, which if you went out to look for it. But many of these are undiagnosed because one of accessibility to care, and even the care that you access, the threshold to diagnose and think about and diagnostics being available is another problem. So I believe that asthma might contribute a high burden even in our low-income settings, because we already have it's highly prevalent, but also mismanaged for a large extent. So nearly 25% of COPD patients generally have a history of asthma. Now, the asthma COPD overlap may also be compounded by other risk factors, pollution, biomass, which worsen asthma, but also increase the patient's likelihood of developing a COPD. So risk modification in this context will require studies to demonstrate the same, but also early diagnosis of asthma, especially in childhood, to offer effective treatment to prevent complications into a COPD, as we will see. Now, there are other occupational exposures which are very prevalent in our setting: vapors, gases, dusts, and fumes. All these contribute to PM 2.5 or PM 10, and our setting is fraught with different economic activities, agriculture, where we are spraying a lot of these chemicals as herbicides, and weeds, where we are burning many things, processing industry, manufacturing. Anyone who has visited a factory, because of worrying things like theft and all, people are locked in a factory overnight trying to manufacture and work on so many things, very often with very poor ventilation, but high production of these toxins. And they're open for in the morning, then the morning shift comes in. So things like awareness and bringing in the policymakers to help those vulnerable workers who are so poor, they need the job, but again, they're exposing themselves to lifelong conditions. So we need to come in and educate, advise on regulation, and also spread awareness, and to kind of avert many of these. Increased industrialization will definitely come with more burden of lung disease if we function the way we are functioning at the moment. Now, the other thing is tuberculosis, something which is very close to the things I do. Now, studies show that TB increases the odds of COPD by anywhere between 3 to 6, and the presentation is variable, because TB can give you either obstructive or restrictive defects, as well as a low diffusion coefficient for carbon monoxide. So the risk is higher among the MDR, but we also know that the risk is very high even with drug-sensitive TB. And this is largely also attributable to things like delayed diagnosis of tuberculosis, which leads to large destruction of the lung, parenchyma, and inflammation, which leads to inflammation of the airways and changes that go on to lead to obstruction or restriction if it comes down to the alveoli. So we know that TB is with us. There are many program efforts to diagnose tuberculosis early, but modifying this. So anytime you're trying to diagnose and treat TB early, you're also kind of reducing the attributable burden of TB to lung disease later in life. However, we still need to screen people who have completed TB treatment, to screen them for COPD and manage them early, because the continuum of TB care does stop at treatment, yet we now know that the burden of lung disease attributable to tuberculosis actually is quite lifelong. As we will see in one of the slides ahead, I'll show you the trajectories of lung function. TB does reset the trajectory of your lung decline, but unfortunately, after TB treatment, we stop following up many of these patients, and many of them have cured microbiologically, but are going on with a chronic lung disease afterwards. Now, HIV, again, through other mechanisms, does lead to a COPD, as you can see from that systematic review of 30 studies. The odds of TB, the odds ratio were anywhere between 1 to 1.25. And we know that other risk factors, again, play into the HIV cascade. For example, tuberculosis, low BMI, chronic respiratory infections, and the damage they cause all fuels into the COPD cascade. So HIV in its own right causes aging of the lungs, as we know that longevity of HIV is happening, and that accelerated aging is also leading to people to reach the threshold for diagnostic threshold for COPD much earlier than other non-HIV patients. So the risk modification for this one, as just like the one for TB, many of the efforts for HIV somehow will enable control of this risk. However, the aging and chronic inflammation is something that's not easy to control for. So we need to do more studies again in these populations to understand what are the mechanistic drivers of disease in these populations, and how shall we be able to solve the COPD attributable to these non-smoking risk factors. Now, I will not go to I will just mention impaired lung growth and early life exposures, but these have been largely covered by Dr. Rebecca. But just to mention that in three large cohorts, which were longitudinal, they were able to show that for people who had a low baseline lung function, 74% of those who had 74% of the people they found who had COPD in those cohorts had low baseline lung function. So for them, it was not rapid decline, but rather the baseline was quite high. So we have already looked at socioeconomic factors, and this is really poverty and the vicious cycle of poverty, which is access to poor care, malnutrition, disease, and limitations in terms of diagnostic and quality healthcare access. So just to highlight what does the literature say, various studies have looked at, for example, the prevalence of chronic respiratory symptoms after tuberculosis. And in this systematic review by Odhiambo and Bimbo and colleagues, published by authors from Kenya, which is nearby, you would see that overall, 41% of patients who had overcome TB had actually symptoms, chronic respiratory symptoms. And these are some of the things that are highlighting that some of these patients might actually be COPD patients who are just coughing away and not necessarily managed. And this risk would be attributable to tuberculosis. Now, when it came down to spirometry, again, 46%, nearly 47% of patients who had overcome TB had abnormal spirometry. And this shows you how much TB does cause in terms of impairments. And many of these studies are from our setting here, including Kayongo from the Nakasuke cohort, as well as The North study was in Bara in 2018. So you can see that TB continues to show how much we've showed that it causes persistence of symptoms as well as abnormal spirometry. Now, when it comes down to a whole diagnosis of COPD, this review by Bayan and colleagues was able to demonstrate the burden of COPD in comparison with the incidence of tuberculosis. As you can see that the last country on this list, which had nearly 1,000 TB cases per 100,000 population, the odds is South Africa on this graph, and the odds of COPD in that attributable to tuberculosis, the odds of TB varying by the TB incidence were anywhere between 4 and 6. So the odds in this study, from this systematic review, you can see that the higher the TB incidence in a country, the higher the risk of COPD attributable to tuberculosis. So when you think about our country, which is anywhere between 100 to 200 TB cases per 100,000 population, but then you can know our current risk. But you also have to remember where we have come from. That, for example, between like 2013, 2014, where we notified about 40,000 TB cases per year, up to now where we are notifying anywhere between 60 to 90,000 TB cases, 90,000 TB cases per year. And from the TB prevalence study of 2015, we know that we should be notifying about 100,000 TB cases per year. So while we miss out a large part of TB not notified, even among the ones we are notifying, there are so many. For example, 100,000 TB cases a year is quite large. So when you think about the attributable burden of TB, that the patients are not dying because our cure rate is anywhere between, I think, 79 to 82 or 85%. Now, those who are not dying are staying with a lifelong burden of having a COPD. Now, this graph does show you the trajectories of a lung function decline using the various risk factors that we have mentioned. You can see that the green one is the normal lung function trajectory, which is like minimal decline and that kind of thing. Now, the blue line is the classic COPD cascade, whereby people smoke and lung function begins to decline at the point where they are smoking, and they reach COPD by the 60th decade. Now, for us in Africa, this classic cascade, for example, if I get tuberculosis at 20 years, TB is going to reset my lung function. By the time I resume a steady state, my lung might be 20 years ahead of my age. I am, let's say, 20 years, but my lung is 40 years. Now, that means that if that person was meant to get COPD at 60 years, they're going to get the COPD at maybe 40 years. And that's the resetting of the lung function decline that we have to be cognizant, attributable to biomass, to tuberculosis, to HIV, to chronic respiratory infections, and the like. Now, the purple line is the one that Dr. Rebecca has largely highlighted, whereby early life events actually don't enable you to hit your threshold. So you end up getting COPD quite early, but you actually have done nothing wrong as an individual, but yours was just a bad start in life. Then the ones who have asthma, interesting, as you can see from this paper in New England Journal of Medicine, they were able to show that even for the asthmatics, your trajectory, much of the activity is happening in the first 6 years of life, what they call the preschool phase. By the time you hit school, the bad things have already happened to your lung function and its trajectory, in that even if you have a slow trajectory, after that, you actually are already destined to get a COPD. Now, this can be highlighted very well in this Melbourne cohort, whereby they were able to track FEV1 in patients, in participants from the age of 10 years up until 50 years. And at 50 years, they sanctioned the cohort and were able to classify the lung function into 4 categories, including no asthma, which was normal control, current asthma, childhood asthma, which had remission in life, as well as stage 1 COPD. Now, they were able to look at the people who had COPD by age of 50. And when they went back and looked at their lung function, they realized that by 10 years, these patients had lung function consistent with the definition of COPD, even at 10 years. So that means that this speaks to this earlier graph that for the asthmatics, much of the damage is actually occurring in childhood. And by the time, and in adult, we are only going to just pick them early, but the damage has already occurred. So this means that we have to really control childhood asthma very, very pertinently to prevent COPD later in life. Now, these are the potential mechanisms of COPD in these different subgroups. And you can see that for biomass and smoking, the mechanisms, airway remodeling and oxidative stress, and the cells at play are the neutrophils, the lymphocytes, and mediators, the matrix metalloproteinases, and different chemokines and cytokines. But this, when you come to asthma, it is airway remodeling and bronchoconstriction. When you come to occupational exposures, it is inflammation. When you come to TB, it is bronchial stenosis, small airway obstruction, obliteration of the matrix degradation by the matrix metalloproteinases. So this TB patient would, for example, be different from an asthmatic patient or from a patient of biomass. Now, when you come to HIV, it is lung aging, apoptosis, altered immunity, chronic respiratory infections, and things like that. Now, when you come to other issues, environmental exposures like tobacco smoke, it is inflammation, oxidative stress. Then you have the group which has early life events like asthma, childhood asthma, maternal factors like maternal smoking, and the like, where you have small airways and alveoli right from the start. So this table can really tell what I'm trying to call a call for action for individualized prevention and care, because every cascade here is actually calling for different strategies for prevention. And even the treatment is going to call for different treatments because the mechanisms are different in terms of cause. So how about the clinical presentation? Now, COPD in smokers, you can see that it's happening at a much later age, starting at 40 years and above, while COPD in non-smokers is coming in at a much earlier age. Then you can see that more males are in COPD smoking. The sex is almost the same, or predominantly females when you come to the non-smoking phenotype. The smoking phenotype has less sputum production, it has more emphysematous picture, while the non-smoking phenotype is more production of cough, sputum, more of the bronchitis picture. Then you can see that they all, interestingly, have frequent exacerbations, so meaning that no particular phenotype is very simple to have because the exacerbations occur and potentially severe in both groups. Then you can see that the risk of lung cancer is also high equally in both groups, meaning that we cannot ignore either group. Then the physiology, there's milder obstruction in the non-smoking phenotype. There's more hyperinflation of the lungs and increased airway resistance, no more DLCO, while we have reduced DLCO in the smoking phenotype. Now, when you look at the CT, I've already said there is more emphysema in smoking phenotype, less emphysema in the non-smoking phenotype. Then the cells at play, more neutrophils are at play in the classic COPD related to smoking, while you have eosinophils also being highly involved in the non-smoking phenotype. Now, when it comes to pharmacological response, you have most studies tailored to the smoking phenotype. The response is unknown in the non-smoking phenotype. But remember, this is the one that we predominantly have by virtue of our risk factors in the low and middle income countries. So this is what I'm trying to say that what I also had to mention was for smoking phenotype, the lung decline is very rapid and consistent with PAC years and does slow down with smoking cessation. However, this non-smoking phenotype, the lung decline might be normal because either you had childhood asthma and your decline is now just normal, or you already messed up at birth, or early life events messed you up. So as we have seen the trajectory, the damage, your lung function is reset at once, then you resume normal decline. But however, these things happen much earlier in life. So in summary, I would like to mention that we have a high attributable burden of COPD, even among the non-smokers. And this risk is higher in our low-income countries, where we have other risk factors like biomass, pollution, TB, HIV, asthma, and the others. Now, the other thing is we have to now begin doing studies to reflect a treatment by virtue of the risk factors that we have in our setting, because current evidence of treatment is informed by smoking study, COPD in smokers, as well as in high-income countries where we do differ by disease phenotype largely. So research is needed to inform our treatment strategies, but also to inform individualized risk, people who have got COPD using different pathways. We also need to educate and create more awareness such that we increase the clinical suspicion of COPD in non-smokers in our clinicians, because once someone says, maybe I don't smoke, then someone may not offer a spirometry or trigger a spirometry earlier, even if someone has chronic respiratory symptoms in that kind of population. And with that, I want to thank you very much. And it's 4 p.m. Thank you. Over.
So thank you, Dr. Ahmed Ddungu. I'm stepping in briefly for Dr. Patricia. I think the storm cannot allow her to hear. But now we'll go into the session for question and answers. We have a few minutes left. So if you have a question, please post it in the chat, or you can raise up your hand. But in the meantime, there was a question, I think, for you, Dr. Ddungu. What is the risk difference for people who chew tobacco as opposed to those who smoke? Is there any difference in risk for COPD?
Okay. Will I wait at once or?
I think you can answer that as I navigate the chat, or you could navigate the chat. There's some few questions as well as I navigate if there is anybody who has put up their hand, but you can answer that in the meantime.
Okay, I think what we have to go back to is the definition of COPD. One is it's a response to exposure to noxious particles and gases and so forth from your local airway environment. That's going to either lead to changes in the inflammatory responses as you inhale, for example, cigarettes, particles from nicotine and related particles from cigarette smoking. Then you're going to, this is the most heightened risk when it's coming down to your airways, where you'll either have coming in of the neutrophils, and then neutrophil elastase will break down the interstitial connective tissue binding the different alveoli, where you can in the end up with either an emphysema, or the inflammation is going to lead to thickening, and then you have bronchoconstriction and that kind of pathway. Now that would be the classic pathway of cigarettes and tobacco. Now, chewing tobacco, I think I don't have a particular study of head, but I do know that any amount of tobacco, whether by smoking or inhalation, is also going to be having an association with COPD. But I may not give you the risk, but certainly it's higher in those who are inhaling directly to the lungs, but someone else can share with us the risk in other tobacco, people who chew tobacco and non-smoking, but it's also present. Over.
Okay. Thank you, Dr. Ddungu. Maybe just to add to that, tobacco is bad. Whether it's chewed, whether you're smoking, just know that it creates a high risk of lung diseases and of really a broad spectrum, not only for the person who is using them, but if it's a pregnant mother, again, the risk is there. Another question was around use of mosquito repellents, whether they also pose a risk of COPD. I don't know whether Dr. Ddungu, you can take on that, but just to start off, it depends on what is in that mosquito repellent, the components. Remember, it is the toxins that you inhale that find their way into your system to cause chronic inflammation, and eventually you end up with COPD. But also for the mother, it's those ones that affect the placenta and eventually find their way into the baby and cause an effect on organ growth and development. And so it's not only carbon monoxide that causes, that is the pollutant. There are so many. There is particulate matter 2.5, 10, different sizes. The nitric oxide, nitrogen dioxide from traffic, and so many other things. So for as long as something has those toxins that we know impact on the respiratory system and eventually can cause COPD, then it can be dangerous. You read that different studies, some of them say there is minimal risk. Others actually have found out that there is a risk. So my take home would be that as long as they have those noxious agents we talked about, then they can't be a problem to your lung health. The other question, there is a hand. I don't know if you can unmute. Baluku, if you can unmute and ask your question directly, or if the admin can unmute you, please.
Yes. Thank you very much, Rebecca and Dr. Ddungu, for the excellent presentations. Mine is more of a comment and probably something to reflect about. The effects of tuberculosis are actually very pervasive. And there's evidence to suggest that if a woman or the parents of a child suffer from tuberculosis, there's a high risk that their children, their offspring, are at risk of asthma and other respiratory diseases. It would be nice to investigate whether indeed parental tuberculosis is associated with COPD in offspring if they have followed up at least for a long time. And so this tuberculosis is not a 6-month disease, and even when the person who suffers it is done with suffering it, even the offspring are actually at risk of other consequences of respiratory morbidity. Thank you.
Thank you, Dr. Baluk, for that addition. Another question is, what is the role of COVID-19? I think it wasn't complete, maybe in the development of COPD. Any thoughts, Dr. Ddungu, or an expert on the platform? And then the other one is that some people after PE, I suppose that is preeclampsia, remain with long-standing difficulty in breathing, or no, pulmonary embolism, remain with long-standing difficulty in breathing. Isn't this COPD? If you can answer those two, I'm hoping Dr. Alupo is back so that she can take over that moderation. Thank you, Dr. Ddungu.
Thank you, Dr. Rebecca. I think the role of COVID-19, is work in progress. And I know that there were, from the lessons learned from tuberculosis, there is also an understanding that I think there have already studies which have shown that we do get there are patients with chronic respiratory impairment and largely attributable to COVID-19. So how quickly, I've not seen a study, for example, linking COVID and COPD, but I do believe that it's a very plausible risk because there were long COVID cohorts. There's a protocol, for example, I read, which was published to try and get the MALT system. I think it was published in CHEST to look at the MALT system effects of COVID-19. And among those, because of the inflammatory nature of COVID-19, it's expected that it will affect or it will expedite someone's destination to COPD. Then, yeah, you already said the other thing about the inhalants, I had cited one of the repellents, that these things that we burn on and stick on the wall. One such repellent is equivalent to about 100 cigarettes to be used. Then I don't know if there's another question, Dr. Rebecca.
I think that's what I was able to see. Over to you, Dr. Alupo, please, to wrap up the session. Thank you.
Thank you, Dr. Rebecca, for stepping in for me, and Dr. Ahmed. I see a question in the chat about PE. I don't know if it was handled.
No, there was a question about pulmonary embolism, that some people after suffering pulmonary embolism, they have difficulty in breathing, I think long-standing. And the question is, isn't this COPD? That's for physicians to answer. Thank you.
Dr. Rebecca, I think I missed that. My network just went off then back.
Is there a risk of COPD after suffering pulmonary embolism? Because some people have long-standing difficulty in breathing after suffering an episode of PE.
I don't think I have an answer to that one.
Okay, I think maybe to help a bit in answering that one, it would go down back to the definition of COPD and what it is. Beyond the difficulty in breathing, we have to demonstrate that there is irreversible obstruction to be able to say that this now is COPD, and maybe see a way to link it back to the PE. But the difficulty in breathing per se on its own doesn't qualify for COPD. There is a criteria that we use to make a diagnosis of it. And so the residual difficulty in breathing could be anything, probably the PE taking on a chronic sequelae or anything else. But I hope that throws more light that for us to be able to make a diagnosis of COPD, we have to demonstrate that as a result of that, there is irreversible airway obstruction at the moment. I hope that has helped the person that asked the question. I don't seem to see any other questions in the chat nor a hand up. And I want to thank the presenters so much for helping us appreciate Dr. Rebecca bringing us to appreciate right from in utero and early life interventions that can prevent COPD, and then Dr. Ddungu highlighting the need for prevention outrightly from the beginning, because they say prevention is better than cure. And usually we realize that these exposures, for example, the mosquito coils, it will be everyone in the household, of the children, the young adults. And so it starts earlier on. And then you've highlighted managing diseases, the tuberculosis, which of course affects any age group. And then also asthma, which often starts, we'll have those that have it in childhood and then also adult onset. But appreciating that all these interventions, when done aggressively earlier on in life, will help towards prevention of the burden of COPD in our setting where it is really heavy. And Dr. Baluku, thank you for highlighting the areas and the gaps for research. There are quite many, and as the Lung Institute, we are dedicated towards doing that, and hope that we'll be able to have more and more answers and strategies to prevent and reduce the morbidity and mortality as a result of COPD in our setting. And with these remarks, I would like to thank you all for attending this DOL session in good numbers. Please keep a lookout for our invite for the next DOL session, which will likely be in early December. And we'll look forward to having you join us again for another exciting, relevant, and interesting topic.
Just a quick one, Dr. Patricia, maybe to inform the members here that we are having these discussions continued during the Lung Health Symposium. That is on 30th.
Oh, yes.
So please look out for the poster and register and attend. We are going to have more lung science to discuss during this symposium. Thank you.
Thank you very much, Dr. Rebecca, and you're all invited for that long symposium. You'll be seeing the adverts soon, and some of you have probably seen them, but please feel free to come and participate in these discussions further. With that, I wish you a good rest of the evening, and we'll meet again next time. Bye.
Bye. Thank you.